Good afternoon, everybody, or good day to you if you're in other parts of the world. Welcome to this seminar on neurological damage in COVID-19, Lessons Learned from the Frontline, a conference that's jointly sponsored by the Physiological Society and the Intensive Care Society. My name is David Menon. I'm an intensivist who works at the University of Cambridge. We have two speakers and a panelist who are going to talk to us about this interesting topic. Just a couple of points. Just on the right of your screen, you will have a button that says submit your questions. Please submit your questions because we'll have hopefully a very lively and informative discussion at the end of the two presentations. If you don't want to give us your name, just precede your comment or question with anon so we know that you need us to keep it anonymous. And we'll discuss all of these at the end. The first of these talks is from Laura Benjamin, who works at the Institute of Neurology at University College in London, and she's going to be talking to us about clinical lessons. Laura.
Thank you very much, and thank you for inviting me to this session. I'm just going to share my screen. Fabulous. Okay, so I'm going to talk about the neurological manifestations of SARS-CoV-2 and give a clinical overview. And hopefully in the second session by Professor Michael Heneka, he can delve into that in more detail. Honorary consultant stroke neurologist at Queen Square and the Institute of Neurology, and also a senior clinical fellow. I've studied infection and neurology and cerebrovascular disease for the last 10 years, and I'm also the co-chair of the Coroner, which is a national repository for COVID neurology. So hopefully I have some insights to be in a position to give you some information and dissect the literature as best as I can. So objective of the next 25 minutes is to talk about the neurological sequelae of pandemics and epidemics, because I think there's a running theme, an overview of neurological syndromes and potential mechanisms, COVID-19 viral dynamic, and I think that's really important to emphasize because we have limitations there, and it's something that we all have to understand. Characteristics of COVID-19 and the epidemiology of what there is, and illustrative clinical cases, management and recovery. So this is a busy slide, but just to tell over the last 2 centuries, all the epidemics and pandemics that we've had. And what I want to emphasize through all of this is that whether it be cholera, or whether it be Ebola or HIV, a viral or bacterial infection, the neurological manifestations often overlap. So for example, cholera, seizures, influenza, which was a problem in 1918 and became a problem again later on in the 2000s. It's encephalitis, lethargica, which we now think is an autoimmune phenomenon, HIV, which is still an ongoing problem, meningitis, encephalitis, neurocognitive problems, peripheral neuropathy, GBS, infections, strokes. And if I bring you down to the lower part here in the early 2000s, you see SARS-CoV-1. And in that time, the was presenting encephalopathy and stroke. Zika you would have heard about, which is more of a problem restricted in South America and Southeast Asia. They had congenital syndromes, meningoencephalitis, transverse myelitis, GBS. And then you have influenza again here, similar syndrome, and MERS, which is another coronavirus, ADEM, encephalitis, brain cell encephalitis, strokes, polyneuropathy. So what I want to show you is that a lot of these syndromes are occurring again in SARS-CoV-2. So there's only so many ways a virus or of infection can cause damage to the brain and hence manifest itself. And thinking about that and expanding that a little bit more, we think about direct invasion of the virus. And it can invade it through breaking down the blood-brain barrier, through hematogenous spread, or through peripheral nerves and transsynaptic spread as well. And in these scenarios, they present typically with encephalitis, meningoencephalitis, meningitis, myelitis, and encephalopathy. And then you have your parainfectious phase, which is thought to be, in very simple terms, innate immunity driven. cytokine storms, these are terminologies that probably come up quite a lot during all these sessions. They're sepsis-induced forms, which leads to encephalopathy and acute hemorrhagic leukoencephalitis. And the secondary to metabolic dysfunction, which can present as seizures, encephalopathy, diffuse ischemia, which I'm sure many of you will recognize in the IT setting, especially with SARS-CoV-2. And secondary to coagulopathy and vasculitis as well. And syndromes in this sense will be stroke, cerebral venous thrombosis, and peripheral neuropathy. And then the post-infectious phase, which is more autoimmune driven, and Guillain-Barré, ADEM, acute demyelinating encephalomyelitis, transverse myelitis, or persistence, which we're not sure yet with SARS-CoV-2, and latency of viral infections. And we see that with HIV contributing to neurocognitive disorders, and also we see that with measles contributing to subacute sclerosing panencephalitis. So what I want to talk here is to put SARS-CoV-2 in the context of other coronaviruses, so SARS-1 and MERS, and to show you its potential as a pandemic virus. In the sense of, I'll draw your attention to this figure here, how long it takes to infect 1,000 people. So for MERS, 2.5 years, for SARS, 130 days, and for SARS-2, 48 days. So what we are probably seeing is not the fact that neurological complications is common in SARS-2, is the fact that SARS-2 is affecting a lot more people, and hence why we're seeing a lot more neurological complications. And then thinking about the virus dynamic and how that interplays with the neurological presentation. So this was published quite early on at the start of the pandemic, and it was a paper from a cohort in Germany, 8 patients, and they swabbed them in different areas: nasal swab, sputum swab, stool swab, serum, and urine. And they swabbed them every day. And what they showed was that these patients started seroconverting around day 6, and most of them had seroconverted by day 8. And also when they cultured the virus every day, they found that they were unable to culture at around day 8. And this has consistently been replicated in many other studies. And day 8, some people who have more severe infection tend to be a bit longer, but generally most people by day 8 stop being infected, and hence why the guidance of self-isolating. And so what does this mean in the context of understanding neurological mechanisms? Well, the first phase where the virus is present, we often refer to as a virological phase. And then when the antibodies start being produced and the virus starts depleting, then we refer to that as the immunological phase. And that has an impact on the mechanism of disease generally. And when we talk about direct invasion, that's probably more relevant when the virus is available and present, and the parainfectious phase, when you have that interplay between virus being present and the immune system kicking in, and then the post-infective phase as well. So these are all terminologies I will use interchangeably, and so just to understand that you can imagine it being quite tricky if someone has SARS-CoV-2. By this stage here, you're not able to diagnose the virus because it's cleared from the system, and then assigning causality may be more challenging. And this is a limitation that's not just a SARS-CoV-2, but throughout most infections. So characteristics and epidemiology of neurology and COVID-19. I have to put the caveat that there is a lot of information and that we're still learning, and it's still, in this context, early days. But what we have seen is the approximate timeline and trying to impose the syndromes that we're seeing in that immunological, virological phase. And what we see here is that we know that we have the asymptomatic phase, so when you start producing symptoms that say 0, and some reports of Guillain-Barré and cerebrovascular diseases occur, so they are the presenting symptom rather than SARS-CoV-2. But most other syndromes, myelitis, ADEM, present a lot later and hence fit within the post-infective, parainfective phase of the illness. Encephalitis is also quite early on. And then again, there's a study in the early phase to just show over 1,000 patients presenting with COVID-19, what the prevalence and the burden of neurological manifestation, of any neurological manifestation, about a third of them will have something. And most of these are usually quite mild and seemingly benign. Dizziness, headaches are quite common. And cerebrovascular disease, which is something that's had a lot of attention, is actually quite rare, 2.8%, and as is seizure and ataxia. The outcome, how do people with SARS-CoV-2 and neurological disease do? There are lots of descriptions of people doing not so well, but this is probably the best study so far, whether it was a case control with contemporaneous controls, comparing cases of stroke patients with stroke patients without COVID. And we can quite see that it's a shift analysis of modified ranking score, where 0 is absolutely well enabled and 6 is death, and everything else falls in between. And you can see that cases who have COVID-19 and stroke tend to do badly or tend to not do so well. And in fact, ischemic stroke deaths during admission was significantly higher in cases 19.8% and control 6.9%. So there is some suggestion that these patients tend to not do so well and also tend to probably have more severe manifestations of neurological conditions. And then this is a series of 43 patients which were looked at the first phase of the pandemic and at the National Hospital and surrounding areas in London, and deeply phenotyped to really understand what was going on. So I'm just going to talk about encephalopathy first and just say the median age was about 57, and the day of COVID-19 presentation, from COVID-19 symptoms to neurological presentation was 4.5 days. So that kind of fit nicely within that virological phase, as I explained before. The main clinical features are delirium, psychosis, but what's atypical is that their CSF are pretty much almost always acellular. And this is not atypical of viral infection and something that's often seen. The MR changes were usually non-specific or normal. Most of them had nasal swab positivities for SARS-CoV-2, and almost all of them had negative SARS-CoV-2 PCR. So again, very difficult to assign causality, but there was a recurring pattern and pattern recognition in these patients. And most of them required only supportive treatment, one steroid, and majority recovered. This is a representation of what we're seeing, and this is the coronary nerve repository that was put together. And what we saw, that these patients with encephalopathy, delirium, neuropsychiatric presentation, they all fall within this similar umbrella. And they tend to be younger. This is the orange, generally. So in comparison to stroke, they tend to be older. So the kind of summary of what we're seeing with these encephalopathic patients or delirious patients or neuropsych patients, and they're all interchangeable, is that they're generally younger. They present in the virological phase of the illness, generally on average. The MRI and CSF are often unremarkable. The RNA for SARS-CoV-2 is really isolated in the CSF, and what does that mean? Is this viral driven or not? And these are one of the challenges that we have. So sometimes what we try to do is look at an indirect way of the virus being in the brain by looking at the immune response to that virus and proving that it's produced more in the brain compared to the peripheral system by measuring the index. And some cases have actually shown that the IgG index of SARS-CoV-2 is raised in these patients. And we don't do that test often, so it's not something that we can say conclusively. And some of these patients also have comorbidities. And then looking at that group of para-infectious post-infections, and as you can imagine, it's very difficult to delineate that group properly. So I've clumped them together. I think the important thing to know is that they present later. So from COVID symptom onset to the neurological manifestation, we're looking at 9, 8, 13 days for your peripheral neuropathies. For the strokes, they tend to have hypercoagulability, so PEs or very high D-dimers. But the clinical manifestation are for the kind of inflammatory CNS, reduced consciousness, oculomotor neuron signs, and the peripheral neuropathies, cranial nerve and peripheral neuropathies, a mixture of both. In this category, as I alluded to with the viral dynamic, you start getting less positivity of nasal swab. And we have to draw on other things to give us an idea that these patients have had SARS-CoV-2. So they may have the typical features like anosmia, dysgeusia, or they may have chest changes that are very classical, but negative in the nasal swab. At this stage, we usually treat these patients as per usual, irrespective of them having SARS-CoV-2. So those with inflammatory syndrome, steroids, those with stroke who show evidence of hypercoagulability, low molecular weight heparin, and those with significant peripheral neuropathy, IVIG. And the recovery is mixed. So these group of patients often have poor disability and don't do as well. So I'm just going to give you some case to illustrate some of these people who fit into this category. So the first one is a 64-year-old man who presented with shortness of breath. On day 10 of symptom onset, he came to hospital and he was positive for SARS-CoV-2. He required CPAP in ICU to support him. On day 15, he had mild weakness and incoordination. On day 19, and was diagnosed with a stroke in his posterior circulation. On day 19, he was found to have bilateral PEs. He was started on treatment dose anticoagulation. And on day 22, he developed an acute bilateral incoordination of the right and right homonymous hemorrhagic, so a visual field defect and incoordination of both arms. So he had 2 events and a hypercoagulable event as well with his PE. He was slightly anemic. He had very high D-dimer. In a stroke patient, that should be less than 1,000 normally. Fibrinogen was also high, which suggested that he was in a hyperclotting state. And he also had these features, lupus anticoagulant, anticoagulin antibody, and anti-beta-2 glycoprotein, which was also positive. And this is something that we've seen quite a lot in these patients. We know with infection that these antibodies can be elevated and are an epiphenomenon, but sometimes these can also be pathological and render you to developing clots. These are his images. And the first scan, this is SWI, just to illustrate these microhemorrhages. And these are typical features that we see in patients who had SARS-CoV-2. And also, in a different sequence, he also had an infarct in that area here. And then when he had his second event, he had an infarct in his posterior cerebral artery, and that gave him his mild coordination and his visual disturbance. So he had 2 strokes despite being anticoagulated. His anticoagulation was augmented, and that seemed to keep things at bay, and he got better. And he's someone who's actually featured in the BBC talking about his experience, and it ended up being a success story. Although COVID-19 affects all adults groups, young patients, and when we say young, we know the median age of patients presenting with strokes is about 75. For someone like him, who was 68, is young. And young patients who are free of vascular risk factors are also presenting. They predominantly have large vessel multifocal occlusions, but other subtypes like hemorrhage, like small vessel disease, are recognized. Thromboinflammation, so that D-dimer, also CRP is a common feature. And those with severe disease and in ITU, approximately 30% have been shown to have asymptomatic ischemic stroke. Arrhythmia, cardiac injury, which can contribute to ischemic stroke, are recognized complications also in COVID-19. And this is just to say that we already know that respiratory infection increases your risk of stroke. And this was shown quite eloquently in this study in 2004. And the highest risk is usually on day 1 to 3, and that risk depletes as time evolves. But what's quite interesting in the study, just quite nicely designed, they showed that patients with COVID-19 had a higher rate of stroke compared to historical influenza. So what it suggests, and the rates, the odds was 7.6. So what it's suggesting is that although we know that systemic infection or respiratory infection can increase, there seems to be an additive risk with COVID-19. And the suspicion is that this is due to hypercoagulability. But much detailed observational studies, experimental studies are needed to explore this further. This is a case of a Parkinsonism, which I think is very relevant for the intensive care patients, intensive care group who will see patients like this and often be perplexed. So this patient presented on day 1, had some pre-symptoms, on day 1 dyspneic, and had saturations of 89%, and was positive for SARS-CoV-2. He had a period in ITU where he was intubated and obviously had a cocktail of different trial drugs, from hydroxychloroquine to lopinavir, and also had azithromycin and methylprednisolone. He was still with deep suction and positive for SARS-CoV-2 at day 26. Note that this is not nasal swab. By day 27, he started developing myoclonus. This was generalized. He had an EEG which confirmed that. He then started having recurrent transient loss of consciousness. He had ocular abnormalities. He became hyperkinetic and had opsoclonus, a wobbly eye. And this is just a video to show exactly what happened with this case. So as he's resting, you can see that he is staring and has a reduced blink reflex, which will occur to hyponemia. His vertical saccades, his quick movements vertically, were slow. He had a resting tremor. And also tremor was present in his lower legs as well. And just a mixed tremor, postural as well as a resting tremor in his upper limbs. I'm not sure if this video is coming up quite well, but just to say that he had bradykinesia as well, so very slowness with his hand movements, just like that. And again, that's just demonstrating that he had corporeal rigidity. So all of this is pointing to the fact that he had Parkinsonism. I'm just going to skip, because of time, to the end to show that he spontaneously recovered by day 50 and was able to start walking. And he's obviously still a bit affected, but certainly much better than he was before. If you can see that. Okay, and his MRI, his CSF, all his tests were essentially normal. He eventually had a DAP scan looking at dopamine uptake, and you can see the outline where the red should be is reduced. So he had reduced dopamine uptake, and that's often diagnostic of Parkinsonism. So that's an example of what we're seeing in this para-post-infective state. And another is that in autoimmune hemorrhagic encephalitis. And just some images to illustrate what we're seeing here. There's an increased T2 signal here, which is obviously clearly abnormal, and hemorrhagic changes as well. And we see hemorrhagic just in the corpus callosum is another typical area where, and microhemorrhages as well. And these are the typical features, and it's thought to be immune mediated. And then this study came out yesterday, and I thought it was important to share it, where they showed, this is a study looking at GBS nationally and looking at the prevalence of GBS in 2016, 17, 18, 19, and 20. And 20 is in red. And if you look through the period of the pandemic, which is the outline going through, peaks around April and comes down again in June. And if you look at the prevalence of 2020, it's going down and goes down further and goes down even further. And the authors conclude that GBS may not be associated with SARS-CoV-2. We also know there's something else going on in these populations where there's a reduction in prevalence of people presenting to hospital. We've seen this with stroke as well. And how much of that accounts for this is unclear, but it's just a thought that what we're seeing, we may just be hyper aware and there may not be an association, as the study highlights. So amongst the varied para-infectious and post-infectious neurological syndromes seen, Parkinsonism is a recognized complication in COVID-19. And there may be additional mechanisms driving stroke, as I alluded to, and GBS may not be associated with COVID-19, but the jury is still out. This is just quickly to, I must mention long-haul COVID-19 because it's something that a lot of people are presenting with now. From a neurological perspective, it's mostly autonomic symptoms that we're seeing: tachycardia, night sweats, temperature dysregulation, gastroparesis, constipation, and peripheral vasoconstriction. And how this has been driven is still to be decided. And also another important thing, looking at psychiatric complications. So red is patients with COVID-19, blue is influenza, it's historical group, and green is any infections. So what we're seeing is that COVID-19 patients disproportionately tend to have psychiatric illness from beyond their presentation, and that seems to increase exponentially away from other infections, and as with anxiety disorders. And this is similarly seen with other infections as well. So it's something that we have to think about as we rehab these patients and they represent to us and how we manage them. So just so we're stop taught to just mention these things, remdesivir, dexamethasone, or the vaccines that are available. We don't know if these are beneficial for neurological complications because the numbers are too small from these trials. But looking at adverse events, it's absolutely negligible, the neurological complications that you get with them, less than 1.5% at best. And you know, there were some reports of ADEM, but you also got these complications in the controls, so it's probably not driven by the infection. So just to mention that, but also to mention all the operational changes that have to happen during the pandemic. So for example, there are many new multidisciplinary team clinics that are setting up now, and there one in Queen Square to support the long-haul COVID syndromes that we're seeing. And the National Neuro-COVID Radiology MDT meeting, which was born out from the pandemic, which is really helpful, and where everyone refers patients to discuss complex patients with COVID-19 presentations. Development of guidance with limited evidence to try and manage patients, for example, strokes with anticoagulation, but the numbers are not large enough to provide trials to support guidance, and the birth of telemedicine, telephone clinics and video consultations and referrals, and that's something that's emerged, I think, positive in the context of operational management. So to bring that all together, there is a wide spectrum of neurological presentations in COVID-19. It's unclear whether the mechanism is causal or coincidental. And there are hints for some of them that it might be causal, but for others, it may be coincidental. And the long-term sequelae is yet to be fully characterized. And I guess on that note, Michael will tell us more about what we know from the mechanistic side of things, but also to highlight that the UK government has actually invested quite heavily on studies, in studies such as FOSS-COVID and COVID-CNS, amongst others, which will help start shedding the light on mechanisms and long-term sequelae as well. So hopefully the future is bright and we can get more answers. Thank you very much.
Thank you very much, Laura. So our second speaker is Michael Heneka, who's works at the University of Bonn in Germany, and he's going to talk to you about the physiological basis underlying some of these findings that you've seen. Michael, over to you. Just a reminder, those of you who have questions, please don't forget to submit it using the Submit Questions tab on the right of the screen, so that we have a rich discussion at the end.
All right, good afternoon, everybody. I hope you can hear me. I'll try to cover the pathomechanisms behind the clinical phenomena Laura has just introduced us to. I have to confess up front that there is not so much information, and we currently gain data and insight every day. So I'll cover what is known, and I have to also point out that a lot of the information I will show in the following talk is filled with speculation and hypothesis due to the lack of really solid studies and results from translational models. So up front, if our body experiences a viral infection, it's the innate immune system, which is our first line of defense. And what that system does, you can see in this little movie here, when macrophage in the bloodstream hunts for a bacterial surface, and it needs to take a lot of clever decisions in order to follow up with it, to be able to catch it and surround it and take it up. Now, this is our first defense system, our first line of defense, so to say, against viruses, fungi, and bacteria. When our body experiences coronaviruses, as we just have heard, in the case of SARS-CoV, MERS, or SARS-CoV-2, there is a variety of clinical neurological syndromes and diseases coming up from Alzheimer's disease, Parkinson's, as we heard, stroke, MS, GBS, encephalopathy, seizures, and brainstem involvement. And interestingly, the reason behind it is the reaction of the immune system against, in the case of COVID-19, against this particle, to introduce you to some of the important features of COVID-19. So we have the spike protein, which binds to the ACE2 receptors on the surface of cells. As we will see, this is an important mechanism of entry. We have the nucleocapsid, the ssRNA, the membrane, and the envelope protein. Now, one paper by Iodekla and colleagues showed that several cells in the brain have different levels of expression with respect to proteins important for docking of the virus, processing of the virus, and actually viral defense mechanisms. And as you can see here, like the vascular, the endothelium cells and the pericytes in the brain are important signs of expression of proteins that enable the virus to dock onto and to entry the brain. There is also expression of viral processing proteins and a lot of antiviral defense systems. Glial cells are weak expressors, but a number of excitatory neurons express receptors that would enable the virus to enter. This shows you a picture what results from infection with COVID-19. And so there is, in red, you see all the areas where global gray matter volume is being reduced in comparison to non-infected cases. axial and mean diffusivity are reduced in the blue highlighted brain areas, showing you where actually COVID damages the brain. And it's interesting to note that these reductions are actually correlating with memory loss and smell loss in these cases. Now, in general, this slide summarizes by which main mechanisms COVID could actually affect brain function. So there is cases and evidence for direct encephalitis and neuroinflammation. There is strong evidence for vasculopathy and vasculitis. The systemic inflammation, so-called cytokine storm, the release of complement factors, chemokines and cytokines in the periphery can have a negative impact on brain function. There is induction of autoimmune reactions, and we also have to think of the peripheral organ dysfunction, which negatively affects the overall brain performance. And finally, being critical with what we do ourselves, there might be modes of therapy which endanger brain function. Now, how can inflammation in general affect the brain? We know that single cytokines such as alpha beta, interferon, and others can suppress long-term potentiation, which is an important electrophysiological mechanism for information storage and consolidation. Inflammation acts in synergy with excitotoxic stimuli, as shown in this paper by Sandy Hewitt and Moses Chow in the mid-90s already. So together, inflammatory stimuli and excitotoxic stimuli leads to the loss of synapses, axons, and dendrites. More recently, a paper has shown that microglia-derived complement-3 in a complement-3 receptor-dependent mechanism can lead to the removal of synaptic structures. And Jonas Neher and Guy Brown from Oxford have shown that microglia cells, once inflammatory activated by cytokines, can even take up living neurons if they do not express the right set of do not eat me signals. Now, this is the first reported case of a 24-year-old man which experienced a direct encephalitis by COVID-19, starting with headache and rapidly developing epilepsy. And here you can see that the limbic system is severely affected and brain tissue obviously is directly involved. Despite we have this evidence of direct brain involvement and massive changes of CSF proteins and other clinical parameters, this slide should highlight that only in very rare cases SARS-CoV-2 mRNAs being found by PCR and points to a direct entry of the virus into this CSF compartment. Now, what are the routes of entry? A prominent route of entry probably is the lamina cribrosa, so the smell system at the tegmentum here of the nose, and you can see here in 2G1 positive neurons which reach out to the nose. Down here, you see that exactly at these positions, SARS-CoV-S, the spike protein, becomes immune positive. There is direct evidence of SARS-CoV-2 by in situ hybridization in this image, and in an electronic optic magnification picture down here, you can see that in these structures, there's direct evidence for COVID-19. So obviously the virus uses the route through the olfactory bulb to enter the brain. And this is further evidenced by this study which shows you that first, in dependence of illness duration, there is SARS-CoV-2 RNA copies being detected in the olfactory mucosa, in the olfactory bulb, R2, in the olfactory tubercle over here, and in other brain areas, including the brainstem. Now, this picture shows you that actually the SARS-CoV-2 spike protein is present within neuronal structures, and obviously these neurons are hijacked to enter the brain into the olfactory bulb. A second possible route into the brain is a transvascular entry by COVID-19 through direct binding of the virus to ACE2, to inflammatory opening of tight junctions, and transfer of viral particles into the perivascular space, and subsequent activation of microglia cells and neurons. So the evidence for such a mechanism and inflammatory activation comes from post-mortem analysis that shows the CD3 and CD5 positive cells as signs of encephalitis, first at the beginning in perivascular locations, and in more advanced cases, widespread infiltration is being observed in the perivascular space, but also in the in brain parenchyma. This results in neuroinflammation, in this case in the olfactory bulb. You see here HLRD are positive microglia cells, which are obviously activated in this case because all the cells are rounded and oval shaped without processes. There is evidence for lymphocyte infiltration into the brain and massive astroglial activation. These are examples from autopsy cases and obviously severe courses of the disease which resulted in death. We do not know whether a similar degree of neuroinflammation takes place in cases that are not so severely affected. Together, this sustained brain inflammation and the activation of the glial cell compartment leads to neuronal damage, as shown here. All the pyramidal neurons depicted are shrunken and hypochromatic, and the surrounding neuropil is edematous and kind of swollen. It's interesting to note that in one of the few animal experiments being done with COVID-19 models and already published, we find that the affection of the lung or the heart is less important for mortality. It's the involvement of the brain, which actually seems to be highly related to the occurrence of death in this mouse model. And in this model, as compared to controls, there is strong evidence for COVID presence in the brains of these mice. So as a first summary, encephalitis or neuroinflammation can affect brain function through the infiltration of immune cells, through local generation of cytokines, complement factors, chemokines, possibly direct infection of neurons. Neurons express the respective proteins important for entry on their surface, and obviously microglial and astroglial activation by secretion of cytokines, and reduction of their beneficial functions can also harm brain function and morphology. Now, a second important factor is vasculopathy, and these immunohistochemical analyses show you endothelial inflammation and thrombosis, which are the two main features. Here you see CD4D positive cells in the lung, and they also can be detected in the brain in vascular and perivascular positions. Now, the degree of inflammation and the nature of inflammation in the of these vessels becomes clear when we see that there is expression of TNF alpha against C4D in a merged position. This is a highly inflamed endothelium. There's IL-6 present in the same position in these vessel walls, and caspase-3 expression as possible sign for a damage. At the same time, we find evidence for the presence of the spike protein in the endothelial cells and ACE2. It's very interesting to note that the ACE2 expression is the highest in the microvasculature of the fat tissue and also the brain. So it's an ideal position or ideal site for the virus to enter the parenchyma behind those vessels. Stroke as one outcome of COVID-19 infection may arise by atrial fibrillation, by direct vasculitis or arteritis, or by, interestingly, rupture of pre-existing atherosclerotic plaques. You see such a plaque here, and you can hypothesize that sustained inflammation in such a position and rupture may give rise to an arterial embolus. In contrast to ischemic stroke, there is also evidence that COVID-19 induces cerebral hemorrhages. And in this case presented here, you see microhemorrhages, mostly in the white matter, but also in the gray matter, and large macrohemorrhages as well. These can be detected in the brain tissue. This is an example of a macrohemorrhage. This is a perivascular microhemorrhage over here. And obviously, the presence of these micro bleeds can have different origins. So there is a collection of cases summarized in this article by Lurcy and colleagues, and there are various hypotheses which are mechanistically unproven but are likely to be involved, like small vessel vasculitis. I just showed you this in the previous immunohistochemical stains. There is obviously cases where anticoagulation has been overdosed, mechanical ventilation as a possible reason, endothelial injury and damage. And also disseminated intravascular coagulation. At the same time, there's evidence for thrombotic microangiopathy. So various reasons, and in summary, there are obviously microhemorrhages caused by COVID-19, by vasculitis, endothelial injury, disseminated intravascular coagulation or thrombosis, therapy caused by mechanical ventilation, anticoagulation, or ECMO. So in summary, vascular pathology may affect brain function through macro and micro hemorrhages, thrombosis of the arterial system leading to ischemic stroke, thrombosis of the venous system leading to intragranular bleeding, damage to the blood-brain barrier and subsequent transposition of inflammatory molecules, and vascular endothelial cell or pericyte-derived inflammatory mediators. As a further component, systemic inflammation and the so-called cytokine storm may affect brain function, and we know from various studies that sustained systemic inflammation leads to the transposition of inflammatory molecules, mediators, and also peripheral immune cells into the brain that further stimulate the glial and microglial cell compartment together, leading to the functional impairment and finally morphological changes of neurons. This is work by Theodore Ivashina showing you in the American Health Retirement Study that people who experience strong, moderate to severe sepsis are prone to develop cognitive decline in the years after. So it's not too far-fetched to hypothesize that patients who would experience a cytokine storm may actually develop similar cognitive amnestic deficits after COVID-19 infection. This is an example from one of our own studies using in vivo two-photon laser scanning microscopy, very mighty method to analyze the microglial cell compartment in vivo, where we can record the behavior of these cells in the living mouse brain, or analyze brain vessels and transposition of particles into the brain parenchyma in response to sepsis. And this is a study using an APP-PS1 transgenic mouse model of Alzheimer's disease, visualizing a beta deposition in the brain. And you can see that 2 days after a systemic inflammatory event, in 10 days, there is a strong increase in amyloid deposition in the brain, which in case we knock down one of the key immune pathways, then as a NALP3 inflammasome is less prominent. When we analyze these brain tissues, then for the content of amyloid beta 1 to 40, we see that we have a steep increase of amyloid beta brain content 2 and 10 days post systemic inflammation, which is not present in mice being deficient for this immune signaling transduction pathway. Now, importantly, we found that microglia cells, which are exposed to a systemic inflammatory stimulus in APP transgenic mice, basically stop removing beta amyloid from the brain. Well, this is not the case in mice which are knockout of NALP3. So in summary, systemic inflammation may affect brain function through peripheral organ dysfunction, elevated levels of circulating cytokines, complement factors, and chemokines. I know of several studies which are underway as we speak. There is transposition of immune factors into the brain, possibly metabolic changes accounting for brain dysfunction and compromised microglial clearance and phagocytosis, for example, of beta amyloid, but certainly of other neuronal debris which may occur during infection. Another mechanism, a fourth mechanism, is autoimmunity, and these are the reported cases of GBS until July 2020. And you can see a high number of cases in Iran, Italy, the US, and Spain. And the question is by which these GBS cases arise. If we look to the possible SARS-CoV-2 epitopes which are shared between human proteins, then we find a high number of possible hexapeptides which are being shared between SARS-CoV-2 and human proteins. And that's a surprise because the general probability that one hexapeptide occurs in two proteins in two species is 1 of 64 millions. Now, the interesting aspect of it is that there are proteins being shared or epitopes being shared which are important for neuronal cells, such as neuronal path domain containing protein 2, the circadian locomotor output cycle protein caput, the adenosine receptor A1, the BDNF 3 growth factor receptor, calcium calmodulin dependent protein kinase 2, an important protein for memory function, the endoplasmatic reticulum manosyl oligosaccharide 1,2 alpha manosidase, which is involved in mental retardation, the glutaminase kidney isoform of mitochondria, which is involved in epilepsy and glutamate excess, and the mitochondrial glutamate carrier 1, which is involved in myoclonic epilepsy. So it's possible that due to the shared sequences, antibodies which are directed against SARS-CoV-2 then affect these neuronal targets and lead to autoimmune phenomena in the aftermath of direct SARS-CoV-2 infection. And finally, I think we have to take into account that peripheral organ dysfunction may also contribute to brain dysfunction, such as the infiltration of the lung and the reduced lung function through reduced oxygenation. Affection of the kidney will result in disbalance of urea levels, electrolytes, minerals, and lead to volume overload. The involvement of the heart will certainly lead to a reduced cardiac output and changes of contraction. The heart, as I pointed out, can also be the source of embolic stroke, and liver involvement will lead to a rise of ammonia, reduced detoxification, disturbances of protein and drug modification, and many other negative factors which may affect brain function. In summary, there are a number of neurological syndromes and consequences for the brain in response to SARS-CoV-2 exposure. Parkinson's disease has been named, seizures, stroke, GBS, multiple sclerosis. I haven't really heard of cases from Alzheimer's disease, but I would expect that the exposure of the brain to increased levels of cytokines may fuel into pathological sequelae that lead to Alzheimer's disease. An important factor is the activation of microglial cells, obviously autoimmunity for many of these dysfunctions and diseases. And I'm sure we will learn, and we are in the urgent need of initiating more studies which will help us to understand the pathomechanisms of COVID-19 with respect to neuronal dysfunction. Since I've shown work from our own group, I thank the members of my group and our collaborators as well people funding our research. And with this, I'm at the end, and I hope you have questions. Thank you.
Thank you very much, Michael. So great talk from both of you. I'll introduce our panelists. Laura, can you turn your camera on as well, please? So you've met Michael and Laura, who've given you these two excellent talks. The third person who's going to be on the panel is Benedict Michael, who's from the University of Liverpool and has been leading on the CoroNerve data collection and is also the PI on the COVID CNS study funded by UKRI. So we have a whole lot of questions, and I think we'll go through them one by one. Question from an anonymous attendee. Are there any, so before that, Ben, would you like to make any general comments to address as a response to the two talks you've heard?
Yeah, thank you, David. Well, firstly, two excellent talks, so thank you very much. I think the only thing I would add is that in the discussions, I think it's probably important for us to acknowledge that there is not such a disease as neuro-COVID, even though that term is used often. I think we have to focus on what the clinical presentations are, and the pathophysiological mechanisms that drive different clinical presentations are likely to be heterogeneous. Thank you.
Or there are many diseases that are neuro-COVID, rather than
another way of putting it, yeah.
Another way of putting it, yes. Okay, so let's get to the questions, because the people who are in the audience that are most important. From an anonymous attendee, are there any common auditory sequelae from COVID, either single ear deafness or tinnitus? Any thoughts? So I'm aware of one paper, which was in the Hearing Journal, where they pulled together 3 or 4 case reports of mild sensory neural loss. Very difficult to know whether that's related to COVID or not, because people are entitled to develop sensory neural loss even without having COVID. So, but that's something that has been looked at. I suppose the question is because the cochlear hair cells essentially are end organs for peripheral nerves. So that's certainly something that's being investigated by people. So this is a hot question, a question from Natalia. If virus is not identified at 8 days, how are my ICU patients still COVID positive after PCR test on day 30 to 40? Any thoughts?
I'll have a go answering that first, if that's okay. Thank you, Natalia, for allowing me to clarify that point. I think on average, for most people who have COVID, they probably stop being infective at around day 8 or so. But certainly there's strong evidence in the studies that have emerged that people with severe COVID, and those would be a lot of people in ITU, tend to have the virus linger for a much longer time. Especially if you are also trying to sample patients with BAL or going even deeper, and you're more likely to pick it up as well. So just to say that what you're seeing is what has been described, but they're in a select population of people with severe disease.
Ben?
Yes, absolutely. And in addition to those prolonged infectious patients, when we're doing the PCR tests, either from bowel or nasopharyngeal swabs, patients are often shedding virus for quite a long period after they're actually infectious, and they're positive by PCR for a long time, potentially beyond the virologic phase. And if, rather than doing the PCR, you actually sequence for nucleic acid, which reflects direct viral replication, you find that those patients aren't actually infectious and don't actually have active viral infection. They're just asymptomatic positive shedders. Thanks.
So for those of you who are interested, there's a nice systematic review in Lancet Microbe, which just came out sometime in the middle of last month, November sort of 15th, 20th, something like that, where they've looked at viral shedding. PCR mean positivity is around 17 days for both upper and respiratory tract, goes out till 83, but in that systematic review, no one had isolated live virus beyond day 9. I'm not sure that that's entirely correct, but it talks to the point that Michael was making, Ben was making a minute ago. Excellent. Question from an anonymous attendee. In inflammatory CNS syndromes, why are upper motor neurons more susceptible than lower motor neurons? Or did they just not check lower motor neurons? Entirely possible, I suppose. I'll ask Laura first and then see what you think.
It's a good point. I guess it's a type where it's affected in the CNS. If it's higher cortical, if it's subcortical, if it's in the cord, then you should be seeing oculomotor neuron signs. If it's in that intersection between the cord and the nerve root, then you may see mixed signs of lower motor neuron and upper motor neuron. Simply put. So it depends on the syndrome they're presenting with. So I think in my presentation that I showed, these are people who are presenting with ADEM, which is mostly more brain disorders. So that would be upper motor neuron. So, but those who present with transverse myelitis and may have involved the root as well, they may present with mixed upper and lower motor neuron. We didn't see many of those in our series, but they have been described, and hopefully they would have been measured and examined.
Let me add to this. Let me add to this that the described cases of Guillain-Barré syndrome are actually showing a lot of lower motor neuron involvement, so I think I totally agree. It depends on what disease and what's COVID-19 mediated or initiated syndrome we are talking about.
Ben?
Yeah, no, I agree with both those points. I think it in part reflects two things. So the para-infectious cytokine storm is likely to cause acute necrotizing encephalopathy, acute disseminated encephalomyelitis, and all these very central syndromes. But then on top of that, as we've heard, you've got this high propensity for neurovascular disease. So in undifferentiated encephalopathic patients with minimal upper motor neuron signs, if they have a prolonged encephalopathy off the ITU ventilator, several studies have now shown a diffuse leukoencephalopathies with microhemorrhages. So actually, I think there's potential, because it's both vascular and cytokine driven, that these patients can present predominantly with central disease with or without upper motor neuron impairment. But it may also reflect where we are in the pandemic. So through the CoroNerve study, we saw a high rate of strokes correlating with hospital admissions with COVID-19, a slight lag in those with ADEM and TM, and then a further lag in those presenting with antibody-mediated diseases like Guillain-Barré syndrome. So it may be actually in these coming months, we have more of these cases that are peripheral to see.
I suppose it's worth reflecting that for the sickest of these patients, which intensivists like me see, most common cause of what would be a low motor neuron weakness is critical illness neuropathy, or a traction neuropathy, typically in patients who are lying prone, or a pressure neuropathy. But we've also described from Cambridge a mononeuritis multiplex, which has just come out in Journal of Neurology, which doesn't fit with any of these and may be a effect on the vasa nervorum. And it provides a very additional, if you like, syndromic manifestation of peripheral weakness. So as Ben said at the start, neurocovid is not one disease, it's many diseases, I think. Right. Question from an anonymous attendee. Why do you think younger people are more likely to show psychiatric issues, and what comorbidities are correlated with this? Laura mentioned some, but did not elaborate.
I'll pass on the question of why young people to Ben, because he probably has more intel with the database. But certain comorbidities are the typicals that we know, such as diabetes, hypertension, people on immunosuppressive treatment. Those are the ones that tend to generally develop neurological complications.
Yeah, thanks. So I think it's a couple of things. So as we've looked more into the granular data, so we've got 600 patients with what we could call neurocovid if we want, through the CoroNerve study. And now we've got detailed case record form data on many of them. I think what we're seeing actually is that many patients are not simply definable as psychiatric. Actually, many of them would meet criteria for psychosis, but also criteria for delirium. Some of whom also would meet criteria for CNS inflammation, and some who would meet criteria for stroke. So what it may well be actually is that there is a large proportion of delirious patients who either have an explainable delirium due to hypoxia or metabolic disturbance or iatrogenic, or an unexplained delirium, which speaks to this leukoencephalopathy issue with SARS-CoV-2, but that also have psychotic or catatonic or manic aspects to their presentation. And it may actually be that this is occurring in older patients, but it's being passed off as delirium, whereas younger patients are much more likely to be referred to a psychiatrist or a neurologist for evaluation and get a label of a neuropsychiatric diagnosis, because they have a greater physiological reserve and are less likely to need ITU and be confounded by the multiple medical comorbidities we accumulate over time.
Michael, can I ask you, is there a biological reason? Because if this is immune mediated, we know that younger patients mount a more vigorous immune response, an adaptive immune response, than older patients. Could that be a mechanism? And if so, would you like to speculate further?
It's a good point, and with respect to levels of cytokines being generated in response to a challenge, as well as autoimmune diseases are much stronger in general in young people as compared to an aged population. On the other side, like host defenses are also weaker in general in the elderly population. I would certainly believe that this is a contributing factor.
Okay. And just going back to the data you showed about the shared hexapeptides between the virus and human tissues, that was really interesting. I hadn't come across that data before. How many of those hexapeptides are cell surface hexapeptides? Because you'd expect the autoantibodies to be much more pathogenic, if you like, if these are exhibited on cell surface. Has anyone looked?
That's true. The paper has not alluded to the distribution on the cell surface, but that's certainly an important factor. The moment cells get damaged, actually, these proteins or these hexapeptides would become visible, so to say, to the immune system and could be equally potent inducers. But it's certainly a point to check, which of the hexapeptides are actually present on a cell surface and which are not.
Yeah, so that might be an interesting thing to look at. A mechanistic question, really, this to Michael primarily. From yesterday's talk, brain parasites differ from cardiac parasites since these have high ACE2 expression. I don't know whether he means brain or cardiac, but from my memory of the Idicola paper, brain parasites don't have high ACE2 expression, but other molecules are expressed. Is this expected, and what are the implications?
So from my reading, they're the brain endothelial cells, or the endothelial cells in the brain and in the fat tissue are a size of highest expression. So I'm not so sure about the parasites, but I actually would believe that it's more relevant for entry whether they bind to the endothelial cells as compared to the parasite. The parasite is located behind the endothelial cells. So for entry via the vascular system, it may be more relevant whether the endothelial cell expresses ACE2.
And my understanding of the literature is that the endothelialitis, which has been described in the lung, has a similar sorts of pathological appearances have also been described in the brain, which would be mechanistically similar, as I see.
Yeah, and I think I showed some pictures where CD3 infiltration and CD5 positive cells were really almost equally found in the lungs as well as in the brain endothelial cells.
Okay, question from James here. What is the prevalence of consequential neurological sequelae at 6 months among survivors? And I think there are three important questions here. One is prevalence, the second is consequential, and the third is the time point. So who wants to have a go at this? Let's start with Ben.
Thank you. Could you ask me in 12 months' time? So yeah, I think we are relatively early on. Clearly, there are people that are 6 months down the line. It's hard to put a number to it. I mean, the anosmia numbers seem to be 20 to 30%. Dizziness, headache, and fatigue might be 70 or 80%. So it depends how you define it. Whereas if you're talking about a defined neurological syndrome, as opposed to neurological symptoms, that mercifully seems relatively rarer. I mean, Laura talked there about the incidence of stroke being, in the order of less than 1 to 5% probably across the various published studies. But the importance being, to your point, David, is the consequence. If these people, often younger people, are suffering a brain injury with limited restorative capacity, there's clearly the potential for lifelong morbidity.
Yep. Laura, and then Michael as well on this. Any thoughts?
No, exactly that. I think it's too early days for follow-up data to really know what the impact is. Hopefully in the next 6 months or so, we'll start getting that information. But neurological consequences, albeit rare, is significant. And it's also thinking about providing the support for these, because you're not just dealing with a disability, you're dealing with all the potential of long COVID symptoms associated with it. And you saw the long-term follow-up of psychiatric patients, so psychiatric symptoms with mood disorders and anxiety will often play its part, especially if they're younger. So it's something that we have to think about holistically, as well as just getting the metrics as well.
Michael?
Well, the University of Bonn is located to one of the hotspots of the first wave in Germany, and this is now 6 to 8 months ago, and I've never seen so many patients calling into our memory clinic asking for advice, because they all report memory dysfunction and loss of concentration and focus, having actually difficulties to go to work. And in my entire neurological career over the past 25 years, I've never experienced a situation that patients on their own call in these quantities into clinic and seek an appointment, and it's really worrisome for me. So I think, as Benedict pointed out, we'll learn and we will have more data on this in the next 12 to 24 months, but I'm afraid it will be way more patients being affected with CNS syndromes as we initially expected.
Yeah. And I suppose we have some insights from what happens to critically ill patients in other settings. Those of us who are intensivists know that at 6 months, up to 30% of patients have significant cognitive deficits after critical illness. And that's the whole gamut of critical illness, both ARDS and sepsis, not the whole gamut, but the important syndromes that we see. And bad COVID, which brings such patients to ICU, is as bad as we see in either of those diseases. So it would be unexpected not to see a similar incidence or prevalence of cognitive deficits. We know that in the follow-up we've been doing locally in Cambridge, that particularly in older patients, it starts getting some cognitive deficit seems to be present pretty universally. How long it lasts for, we don't know, because most of our follow-ups have been 3 to 6 months. The literature, as far as I know, there was one paper from the Italian group, which was Carifi, that was in, I think, in JAMA Internal Medicine some months ago, but they didn't actually ask questions about memory. There was also a paper that appeared as a preprint some time ago, but that was restricted to 30 days. But the thing that stuck out for me from that was that of the patients who had 5 or more symptoms, one of the dominant symptoms was memory loss, exactly as Michael says, but you also had fatigue and you had headache and agusia and anosmia. Now the last two, just are not neurological exclusively, but it seems as though once the systemic findings or the systemic symptoms start becoming a little less and the deconditioning is less of an issue, maybe these neurological symptoms will emerge. How much, we just have to wait and see. So this is a really interesting question from Simon. So Michael, what compromises are likely in a mouse model of neuro-COVID, of COVID in general, I suppose?
Well, I think this is a question that relates to that questions the value of mouse models. And frankly, with respect to COVID-19, we don't have data yet which would tell us how great the translatability of murine model data into the human system and back is. But in general, there is a very elegant paper by Sook and colleagues in 2013 published in PNAS analyzing the difference in adaptive and innate immunity between mouse and man. And it has to be stated that approximately 30% of the adaptive immune pathways are being shared, while 40% of the innate immune pathways are similar or identical in murine and human systems. So there is something, some of these signal transduction pathways and systems are being highly conserved between both species, but others are not. And the question is which are being engaged in response to COVID-19 infection and which are not. And we will have to precisely look whether COVID-19 affects different systems in a mouse immune system and in particular in the mouse brain as compared to human cases. But there is no data which have analyzed this in detail so far.
So let me ask all three of you, as people who are working clinically as well, if you did have a good faithful mouse model, what is the question that you might want to ask of it that you can't ask from our clinical experience? I'll start with Michael.
Well, I probably could be easier to test therapeutic interventions and direct biochemical and immunological reactions of the brain. I think a mouse brain can be analyzed by different means, and the most of the tissue I've shown you, tissue analysis I've shown you, was from post-mortem brains. So there are two problems. First of all, they have a post-mortem interval, which may have their own problems and changes, and then it's only from the very severe cases. It's biased from the beginning. So a mouse model can give you a wider variety and probably more mechanistic insight. You can start to knock out certain single transduction pathways, and you can test therapeutic interventions much easier in a mouse model as compared to the human system.
Sounds like a great grant, actually, Michael. Reply. Laura, what is it that you're seeing in your patients that you wish you had an animal model to answer?
It'd be quite nice to track the virus and see where it goes, because so far it's evading us. I think we see patients that look as if they've had SARS-CoV infection, but we can't find it in the CSF, we can't find it in brain tissue when we do autopsy. So it's actually trying to demonstrate causality in the sense of how the virus enters, and where is the optimal entry and what it actually infects. We've got nice organized data kind of giving some indication, but it would be useful to take that forward in an animal model as well.
But even if you had an animal model that didn't allow virus entry to the brain, but had the host responses that were similar,
yes,
it would be quite interesting to see whether we could replicate all of the syndromic appearances, because then in some ways you're dissecting out the host response, even if they got just a pneumonia but a big cytokine storm. That would be quite interesting, I think.
Definitely.
Yeah. Ben.
Yeah, so in Michael's defense of the mouse model as well, we looked at in other viral infections which affect the brain and found that myeloperoxidase was the strongest predictor in CSF. Took that into the mouse model and published this year that CXCL1 was the CXCR2 ligand driving neutrophil migration and blood-brain barrier breakdown in viral encephalitis. And I've just got some MRC funding to take that forward for the next 5 years. So we've seen in patients high levels of CXCL9, CXCL10, and MMP9, and we've seen some disruption of the blood-brain barrier. So the question I would want to ask from the clinical data in the mouse model would be, can we drive, either as David mentioned, through a para-infectious, or as Laura would want to do, through a directly infectious process, although the former seems to be more common in our patients. Can we drive blood-brain barrier disruption? And if we can, what does that mean for migration of these CD4 cells that Michael's been talking about, given these high levels of CXCL10 that we've seen in patients with severe disease. And if we can do that, well, we know there are drugs which stabilize the blood-brain barrier, like dexamethasone, which has proven so useful in COVID disease of the lung, and of course, intravenous immunoglobulin and other immunosuppressants, which may have a role in our otherwise unexplained encephalopathic patients who have got blood-brain barrier disruption or leukoencephalopathy or encephalitis of some other flavor.
Or you could perhaps disrupt the blood-brain barrier using other mechanisms like mannitol infusion and see where the neuropathology increases. So that might be the other possibility of addressing the cytokine storm, endothelial breakdown, and so on. So there are many opportunities there. It sounds as though three of you should apply for a grant together. There you go. And then we have a question from Sotirula. How common is impaired swallowing reflex in elderly COVID-19 patients, especially if, oh, there's a question before that. I'll come to it in a minute. Swallowing in elderly patients first. Any thoughts?
So we've had several patients who've had that. And of course, we've had isolated cranial neuropathies as well. And some of it seems to reflect a brainstem encephalitis. But for many more, it actually seems to reflect almost a mononeuritis multiplex. So we've seen isolated sixths, isolated sevenths, but also isolated glossopharyngeal nerve palsies as well. But on the post-mortem tissue that we've evaluated, we're unable to recover virus. So it seems to be para-infectious or post-infectious, if anything.
Okay, this I think is the last question from an anonymous attendee. Are ciliated ependymal cells of the ventricles targeted by COVID in a manner similar to ciliated cells in the nasal mucosa? Some of the cases shown by Laura have a very low virus in the CSF, in parentheses. Michael?
In general, there is very low CSF detection of virus RNA copies. I have no information on ependymal cells in the ventricles, to be honest.
Okay. Okay, so we're coming to the end of the meeting. We have no other questions, just a comment from Michael 2 minutes ago that he has to leave in 5 minutes. So I think I'll take the last 3 minutes we have, first of all, to just summarize what we found. First of all, neuro-COVID is not one disease, it's probably multiple diseases, or it isn't a disease at all, one of those two options. There are multiple mechanisms that may result in neurological insults and sequelae from COVID, and we've heard both the clinical manifestations of those, the epidemiology of those, and the mechanisms, and some really nice talks and discussions. We don't know how long these things are going to last and what the long-term sequelae and outcomes are likely to be, but we'll unfortunately know much better over the next 6 to 12 months. We've had some opportunities from animal models, but we may have to have some caveats, but still addressing individual mechanistic questions would still be possible in those models. And hopefully in a year's time, when we repeat this, we'll have much more to discuss and much more to know. So thank you very much to the speakers and Ben as the panelist, and to all of you for listening. Thank you very much.
Thank you.